Okay, well, good evening and welcome to everyone, both those of you who are on video and those of you who are traveling and listening. I was just saying, I think we've got a lot of good news tonight for this meeting, so I'm looking forward to the meeting. We have several apologies, one from Kath Hannon and the other from Ian Pettigrew, just to be registered. And I'm now going to officially open the meeting. I am currently in Meanjin, Brisbane, at a bioethics conference, and so I'm delighted to be able to be broadcasting to you tonight. I would like to begin by acknowledging the traditional owners and the custodians of the land on which I broadcast from, namely the Turrbal and the Jagera people of Meanjin, and I wish to pay my respects to elders past and present and to emerging leaders, and I extend my respect to Aboriginal and Torres Strait Islander people here today. If you could put yourselves on mute unless you're speaking, and for those of you, when you ask a question, if you could introduce yourself using the chat function, that would be great. If anyone's new to the meeting, we'd love you to just speak up and say hi, because I don't want to be ignoring people. And we have recorded them. We do always record these meetings so that you can get them from the Search admin website. Is there anyone who's new to the meetings that would like to say hi and a bit of a hello? No?
Hi,
Okay.
I'm Shelley Fawkes. I'm from Sunraysia Community Health Services in Mildura. Yasmin Burney probably attends these meetings.
Yeah, look, I was actually staring at you, Shelley, knowing that you wouldn't be able to realise I was staring at you. This is the thing with Zoom. Oh, look, that's really nice. So you work with Yasmin.
That's right, yes.
And you're one of our announcements. You're the new hub, aren't you?
That's right. So we've had a STI BBB program for probably 3 or 4 years now, and it's just recently been announced that will become a hub. So we're just getting everything organised at the moment and hope to have that, increasing our capacity and fully running by the start of the new year.
Well, that is absolutely fantastic news. And I know that Kath in particular has been in touch with Yasmin, and we just want to again extend our offer of whatever we can do to help with support, as with resources or personnel, whatever we can help with. So
that's great
to hear from you. And anyone else who's new to the meetings that I may not? Yes, Genevieve. Yeah, would you like to say hello?
Hi, Paddy. Yeah, I have not been before, I don't think. And
I don't think so either.
No, so working in Western Victoria with the Public Health Unit on the Sexual Health Plan.
Fantastic.
As a sexual health nurse.
Yeah, welcome to the meeting.
Thanks.
Hi, I'm Rosie Brennan. I'm the Sexual and Reproductive Health and Viral Hepatitis Lead at NEFU, the Northeastern Public Health Unit, and I've previously worked at the Women's with Kath Hannon. So yeah, this is my first time joining. I'm about to jump into the car, so yeah, I'll just be listening in this minute. Thanks for having me.
That's really great to have at least 3 new people tonight. So you're very, very welcome, Rosie. Our first item on the standing item on the agenda is to cross over to Carolyn from 1-800 My Options with a bit of a snapshot of the current landscape with regard to provision of services, what's happening, what's hot and what's not. So thank you, Carolyn.
Thanks so much, Patty. Thanks, everyone. My name's Carolyn. I'm the manager of the 1-800 My Options service at Women's Health Victoria. So I'll give you a bit of a snapshot of where 1-800 My Options is at in terms of demand and service provision that we're seeing across the state. But I've also got a preview of the new Atlas data to show, which is showing medical abortion and LARCs across the state for 2022. It just went live on the website last week. It's quite exciting for those into data. So first of all, from a 1-800 My Options point of view, we I guess every time we meet, I say the same thing, but we're busy. Demand continues to increase. We always see a trend of increasing calls as we get to November, December. It's happened a little bit earlier than it has in previous years this year, though. Not quite sure why that is, but one thing I can reflect on from our callers and the data that we're collecting is that there's a lot of financial insecurity, and this is a time of year that becomes more difficult. And so we're seeing more people just unable to afford sexual and reproductive health services. So currently we're getting around about 32 calls a day, and 85, 90% of those callers are looking for abortion services. Around about 20% of our callers are coming from rural areas, and it's quite well spread across rural Victoria. We I think that the biggest issue that we're seeing right now is financial insecurity. We are still continuing to see a lot of people who just have really very low levels of literacy around sexual and reproductive health. So a lot of confusion around how do you tell how far along you are for a person, but also around medical and surgical abortion. So while we're starting to see for the first time since the service was established a bit of an evening up of demand for medical and surgical abortion, which is really exciting. We've always had a significantly higher demand for surgical abortion. There's still a lot of confusion around what medical abortion is, how the experience will be, what it will look like, how long they might experience bleeding, etc. And I think that mythology plays into that quite a bit. As I'm sure all of you know, you're hearing this every day, people's confusion and worry about medical abortion. We are also seeing demand for LARC continue. One of the great things that we've been able to do in addition this year is get more bulk billing or low-cost ultrasound providers on our map. So we've got about 700 providers currently, and it's not always obvious on the map which ones will be low-cost or bulk billing, but if people call us, we can normally find somewhere where they'll pay less than $100 or it'll be bulk billed, because that cost had been becoming more and more prohibitive for people across the state. I'm not sure if this is an experience that others are having across the state around the difficulty of accessing bulk billing ultrasounds, but it's become really difficult from what callers are telling us too. So I might flip over and give you a quick look at the data that we've got for the Atlas. So this was published just last week. I don't know if it's been announced formally for our email list, but here you go. You're going to see it anyway. We have previewed it for the Department of Health, and we're also really happy to talk to anyone who wants to have a look at this data and have a chat about what it means from a Women's Health Victoria point of view, but also how it relates to 1800 My Options data. So for those of you that are not familiar with the Women's Health Atlas, it covers over 61 indicators for health that range across a variety of topics. The interest for 1800 My Options is sexual and reproductive health, and under that we've got STIs and BBBs, and we've also got medication abortion, contraceptive implant and hormonal IUD data that was published just last week. So here we've got the number of services, and this is the total statewide for Victoria. And you can see how it applies from 2018 to 2022. The really important figure to look at is the patient figure. So the patient figure is the number of prescriptions that were received by residents of Victoria in any given year. So in 2022, we had now 9,379 Victorian residents who were Medicare eligible, who received a medical abortion script under the PBS, and that's an increase from 5,500 in 2018. So we're seeing a consistent increase in demand for medical abortion. The third column there that is prescriber statewide total, that's the number of prescriptions written under the PBS by prescribers registered in Victoria. It's significantly higher than residents, and I think that relates specifically to cross-border prescribing, also to a lot of telehealth prescribing across borders. And the third column is a really interesting one again, and that's lower than the patient total, and that's the number of prescriptions that were dispensed from pharmacies from within Victoria. So we've had a chat to a few different organisations and agencies about why there's a 2,000 discrepancy between prescribers, between dispensers and between people who received the abortion script themselves. It would seem that it's attributable to telehealth providers who are sending it from interstate, as well as a lot of the online pharmacies, or the pharmacies where people can order online, are sending out of Queensland in particular, but also other states. That's what we understand about this data. If anyone else has other insights, we're really keen to hear about them. But that's the reports that we've had from a few different avenues. So overall, we're seeing some really great consistent increase in demand for medical abortion. But what we see that's not consistent is patients and prescribers and their locations. So this is the number of services by patient location in 2022 on the left side of the screen, and it's showing that there is demand for abortion all across the state. There's no LGA in Victoria where somebody did not receive a medical abortion. But the map on the right is showing where the prescriptions were written from. And so you can see there's a couple of regions, Grampians in particular is that golden highlighted one, aside from Horsham and Ballarat. And that gold colour is showing where no prescriptions were written for medical abortion in 2022. So we've got a significant area across Western Victoria and then a little bit in the north as well. It's also worth noting there are LGAs in Melbourne where there are fewer than 30 prescriptions written in 2022, which is extraordinary and also quite alarming. So when we flip this over to look at 2021 versus 2022, you can see that there are 4 more LGAs where prescribing is happening since the previous year. So in 2021, there were 12 LGAs with no prescribers. In 2022, it was down to 8. That's a really great improvement, but it's really obvious that there is an area of Victoria where there is consistent lack of provision of medical abortion. Please interrupt me if you've got any questions. I'm not going to be able to see the chat while we're talking about this, so just shout at me. That's completely fine. And then we can also compare patient location with pharmacy location. And again, it's the same region across the Grampians and Western Victoria where there are pharmacies that are not dispensing medical abortion and a few other little hotspots across the state. But frankly, when you look at the pharmacies and patients and prescribers side by side, Western Victoria has people wanting and receiving abortions but not being able to access the prescribing locally or even the dispensing locally. So when we look at pharmacies again, there are 5 more LGAs that are dispensing as opposed to 2021, but we've still got a significant number of LGAs where no dispensing is happening. And there are 7 LGAs across the state where there is no prescribing and no pharmacies happening whatsoever. And again, they're the usual suspects across that Western region and a little bit across other parts of Victoria. So the rate per 1,000 is really interesting as well. So we're actually seeing a really consistent increase in the rate per 1,000 women of reproductive age who are accessing medical abortion. It's gone from 4.5 in 2021 to 5.3 in 2022. The increase is marked and it is consistent. The increase is a little bit less across prescribers and pharmacies, but it's still continuing to increase. We're seeing a little bit more provision across the state. And here we have the rate per 1,000. We've got patients on the left. So you can really see that that rate per 1,000 people of reproductive age is really consistent across the state. It is a really consistent blue. Generally, there is consistent demand for medical abortion. But again, when you look at the rate for prescribers, which is the middle map of Victoria, there are some really bright blues in places where people are obviously accessing a lot of medical abortion. surrounded by those yellows, where there is 0. And again, for pharmacies, you've basically got little beacons of provision across regional Victoria, surrounded by limited or no provision whatsoever. I know I'm not telling anyone anything surprising here, but it is really interesting to see the picture here. And I think one of the things that really stands out when we look at these maps is for areas like Horsham and Mildura, where there is provision, it's obvious that people in the surrounding LGAs are just not able to access these services anywhere apart from travelling those hundreds of kilometres to get to Horsham or Mildura, or by telehealth or online services. I know that I'm running out of time, so I'm going to quickly go through the contraceptive stuff, but this is alarming too. This is for Implanon. This is contraceptive implant number of services. You can see providers and patients, and we've seen a drop from 2019 to 2022 in Implanon provision and in Implanon uptake. And when you look at this next to medical abortion demand, I mean, it's concerning that we're seeing less LARC use across the state, particularly when Implanon itself is something that we assume is available in most GP practices across the state. This is showing the patients with providers for the contraceptive implant. And again, we've just got this swathe of Victoria where there is very, very little provision happening. And again, when we look at the provider location, there are some parts of Victoria, again, and they are the usual suspects, where the rate is very, very low. I know I'm zooming through these slides. I'd encourage you to have a look at it more closely. This is contraceptive IUD, this is hormonal IUD, and again, we've got the same thing happening. So between 2021 and 2022, we've had a reduction in services for hormonal IUD. I'm not quite sure what this is about. I would have thought it would continue to increase, but this is not what we're seeing from the data that we received from the PBS. Again, what we are seeing is some pretty consistent demand, but the provision is not matching the demand. People are having to travel significant distances, and there are still 3 LGAs with nobody who has been inserting IUD, hormonal IUDs. Again, they're in the same regions that we expect. When we look at the rates, again, the demand is really consistent across Victoria. There's that consistent blue across most of the state where people want to be able to access a hormonal IUD. But again, the provider rate per 1,000 women is not consistent across the state. And again, we're starting to see those hotspots pop up. Grampians is the one. I'm really sorry, Grampians folks, Genevieve. We talk about Grampians a lot when we're talking about SRH access, but again, you can see that the things that we talk about when we're talking about providers in Grampians, you can see it really clearly on this map where there's just no provision happening in that region. There's significant distances for people to travel, and again, you can't get an IUD via telehealth. So people have no option but to travel significant distances. So I'm going to stop there. If anyone has any questions, they're really welcome to shout out, and I will drop the link to the atlas as well in the chat so that you can explore it in your own time. And I will also drop my email address and that of my colleague who manages the atlas so that you can all get in touch with us if you'd like to have a bit more of a closer look at that data or a discussion about what it means and how it applies to your area.
Carolyn, do we have no data on copper IUDs
No.
because they're not PBS? Is that
Not
the
PBS, yes, no.
I know I'm putting in more, but that's just completely anecdotal that I've got a lot of women who are choosing the copper instead of the hormonal, but I'm not saying that that's taking over that massive number. But
yeah. I think we have a consistent demand for copper IUD at 1-800 My Options, it's not accounting for that difference. I don't actually know how that difference has come about and how the drop has come about.
I'm wondering, Carolyn, could it have something to do with the cost of the GP appointment?
Yeah.
And inability to afford to travel even,
Yeah.
or to actually pay for the service, which is probably no longer bulk billed in quite a few places.
Oh yeah, I absolutely agree. I think that when we look at a cost benefit analysis of a hormonal IUD over 5 years, it's really, really effective, isn't it? But it's still a significant upfront cost, and a lot of people don't have that kind of disposable income to be able to pay around $300 or so to have the IUD inserted at a standard GP clinic. And so it's just not accessible at all. But the thing that really worries me alongside that is that the insertion cost for an implant-on is generally not as expensive as it is for a hormonal IUD, but that's still dropping as well.
I feel
Does
like
anybody else have any,
I feel like it's a combination of all those things and a real movement away from any hormonal contraception. I feel like we're seeing many people coming to our clinic going, I don't want any hormonal contraception. So I think it's potentially a combo of cost in terms of seeing a GP, people can't afford it and there's no bulk billing. It's an uptake of copper IUDs, like you said, Siobhan, and that there's this real movement away from, with TikTok, good old TikTok, away from any hormonal contraception at all. So I think there's quite a few factors from what we are seeing up our end. Yeah.
Yeah, we definitely hear a lot of the myths about IUDs on the phone line, and I don't know if any of you have ever delved into the land of Facebook groups for hormonal IUDs, but they are extraordinary places where misinformation is just peddled across the board. And I think that there's a real concern amongst women that they'll have an IUD inserted, but it'll be difficult to have it removed, whether they're concerned because they've had a doctor say to them, oh no, leave it a little bit longer and see how you go. It might be worth keeping it in and we'll remove it, in another month, or whether they're just worried about that happening. I think that concern is really real, and it's being perpetuated and made worse by people's stories and the mythology around IUDs.
Carolyn, is it dropping in all age groups? Is it broken down by age groups on your site, or is it just a gross figure?
It's just a gross figure. It would be really fascinating to see the age group distribution.
I must say that teaching the medical students this year, someone came up with this acronym of teaching about contraception, and one of the and I can't remember what the acronym was, but one of the things was no Google. That's what they were going to teach their patients. No Googling allowed.
Yeah, fully agree. So I might leave it there because I know that we've got a pretty tight timeline, but don't hesitate. I've put 2 email addresses in there. Don't hesitate to get in touch with us or the Atlas team to talk about that data more if you'd like to. Thanks.
That's absolutely fantastic, as always, Carolyn. And this is becoming a bigger and bigger database, which is so compelling when we are advocating for the next round of hub formation, the next announcement of where a hub should be. It's, the colors light up if the Department of Health wants to pay attention, and really shows, that we need the providers everywhere, and we need to make it local, or it's not going to change anytime soon. I'm going to now, is there any other questions? Are there any other questions? And if not, I will move on to just one of the announcements or introduction is the launch of the RANZCOG abortion care guidelines that I was involved in developing. And I'm just going to share this. Hopefully I can share my screen. Here we are. And we'll go from the top. Just need to get rid of something to show me the slides. So we've already done our acknowledgement of country, but I just love this piece of local artwork, which is a depiction of the Brisbane River Maiwar, which is an embodiment of the spirit eel. And then I'll just talk about the RANZCOG abortion care guidelines, which I've been involved in developing over the last 2 years. And just to give you a little bit about background and a little bit about how they work, and invite your comments on them. So these were finally released and announced at the ASM, the RANZCOG annual scientific meeting, just at the end of October in Perth, Western Australia. And I can report that they were really well and enthusiastically received by the membership that attended. So what has been developed is a twofold tool, a clinical guideline for abortion care and an accompanying abortion decision aid. Now, they were printed in a limited print run, which was rapidly swallowed up by the delegates at the conference, and they're going to put out another print run because of the huge number of people requesting physical copies to have. However, they are available to download from the website for free. So just before I go on to what the purpose of it was, this was an enormous undertaking. And one of the things that I'm particularly proud of is that this was the first evidence-based guideline that the college engaged in after the formation of their faculty of evidence-based guidelines. So they have appointed an academic lead for that faculty and 2 permanent research staff for the college. And after some lobbying by the Sexual and Reproductive Health interest group that I am a member of, the Women's Health Committee decided that abortion care guidelines were going to be the first one. The other thing that I'm really pleased with is that they used they accepted our term of abortion care guidelines rather than abortion guidelines. I know it's semantics, but I think I particularly like the fact that it's regarded as abortion care and that it's regarded as health care. So the purpose of the guidelines was to provide evidence-based recommendations, to be as up-to-date as possible, and to enable regular review. So the review is going to occur every 20 months on a cycle. It was for practitioners who supply advice and abortion care, and to be freely available for medical, nursing and midwifery for Australia and Aotearoa New Zealand. And that's significant because there are different legislatures in those countries. Medical abortion is prescribed under a different set of restrictive legislation. It's provided in different format, and it's provided up to 10 weeks in Aotearoa. The circumstances are generalized circumstances, so we deliberately admit that the guidelines don't go into all of the possible combinations. What if the patient wants a surgical abortion, has already had 5 cesareans, for example? It's more the commoner circumstances that you would encounter. It covers 1st and 2nd trimester. And for the purposes of the guidelines, and based on the previous Cochrane and NICE, the Cochrane reviews that exist so far, and the NICE guidelines of 2021, 1st trimester is defined as up to 13 weeks and 6 days, and 2nd trimester from 14 weeks onwards. They also cover medical and surgical. So I'm just going to talk you through a little bit about how the guidelines were developed, and then give you a couple of keynote or examples that really particularly refer to the work that our network is involved in, and that's mainly the 1st trimester services, of course. So a decision was made as to what was in scope and what was out of scope of the frameworks that we were using. And throughout the whole process, and when we submitted them for general comment to our membership, we got lots of feedback going, you haven't covered this, you haven't covered that, but there was a definite decision about what we were and we're not going to cover, given the limited resources that we had. So in scope was as much evidence-based guideline as we could around physical, social and psychological support for women considering abortion, including routine testing, medical abortion, including treatment regimes for early medical abortion, follow-up and pain relief, and also including telehealth recommendations. With regard to surgical abortion, including optimal regimes for cervical priming prior to surgical, techniques including manual versus electric vacuum aspiration, analgesia, and approved indications for infection management, management of complications and follow-up, including abortion following uterine surgery, incomplete abortion or ongoing pregnancy, and post-abortion care covering post-abortion contraception and routine follow-up. Out of scope deliberately where any discussions about funding recommendations, Medicare, etc. The cost of an abortion service, so there were no guidelines about what it should cost, because this was not something that we were engaging in. That's a different process. Fetal reduction was not covered. Sometimes fetal reduction is requested in multiple pregnancies. Off note, a decision was made not to provide evidence with regard to screening for family violence, mental illness, and the discussion of informed consent, as these are regarded as part of routine clinical care and covered extensively in other guidelines and initiatives, both at a national and a state and local level. Similarly, we didn't engage in any evidence about the incidence of the provision of misleading clinical history by women, for example, for gestational age. Now, I wouldn't even have bothered to mention this, but this apparently was a recurrent theme by some of the anti-abortionists within the RANZCOG membership, that we should have addressed the number of women with misleading clinical histories. I think it's totally irrelevant. Abortion performed by non-registered health professionals was another area that we certainly didn't engage in. And that includes the provision of self-managed abortion or abortion doulas, movements that are both quite common and increasing across both the global north and the global south. But we did not see the need to provide any information with regard to those. The methodology, the guideline unit was formed in 2021 with two full-time researchers and an academic lead. Then expressions of interest were called for the Guideline Development Committee. 12 members, including myself, were appointed with I felt a really good cross-section of primary care providers, hospital providers, gynecologists, GPs, midwifery, and academic providers of research and care. The methodology was to develop a list of clinical questions, and in total 17 clinical questions that we felt needed to be answered were established. And then each clinical question was interrogated thoroughly. We referenced the Cochrane strategy and used the NICE guidelines, to, the most recent of which was in 2019, published with its data closing in 2018. If there was further, and we used their search methodology and their search strings for our literature searches. If there was a paucity in some of the areas, we repeated the search after 2018. And we extended our research up to the end of 2022, October 2022. In total, over 16,000 articles were scrutinized by these fantastic research elves that we had, and then the group met on a monthly basis and interrogated the evidence and graded the evidence. If it was qualitative evidence, we used the CIRQUAL technique for qualitative reviews. And what I will point out is, look, this is really, I think, probably not going to tell many people any news, but the provision of abortion care is a relatively evidence-free area, because it's not an area in which high-quality double-blinded randomized controlled trials have ever been seen as appropriate. And most evidence is either observational or from expert guidelines in the past. So given that, we included consensus recommendations and also made good practice points when we were not able to determine that something was an evidence, had a strong evidence base. So I'll just go ahead and then come back again. So the range that we looked at, where we looked into telemedicine advancements, we looked into routine testing, we supplied information with regard to the pain relief strategies, antibiotic prophylaxis. And here the guideline is very clear that antibiotic prophylaxis is recommended for all women having
I think we've lost Patty there, have we?
I think we have.
I think we have. She froze. I've just sent.
If you sent, I don't have it. Yeah, if someone can text her, that'd be great. Yeah. It was hard to work out whether the freezing was just at my end or something. Quick drinks break, everyone. You're on mute, Siobhan.
Anybody else know what the agenda was after Patty?
Oh, let me. I'm just finding the agenda now.
Thanks. Thanks
please
both. Please hold.
I've got it up. So the next item was to talk to the nurse practitioner and endorsed midwives providing MS2 step. So in light of the recent deregulation, what is the current status for nurse practitioners and endorsed midwives to provide MS2 step? What supports are needed to build workforce capability?
Who was speaking to that?
I can't tell you. It might have been Patty again.
It might have been Louise and myself, actually.
Yes.
Yeah.
Awesome. Do you want to go ahead with that while we find where Patty has disappeared
Yeah,
in
totally.
Brisbane?
I'm not sure if Louise is still online or not. So,
yes,
she is. Excellent.
Well, she seems to still.
So, at this stage, as far as provision of abortion care and prescribing of MS2 step, I feel confident and competent to prescribe if a patient turns up with the ultrasound with them already been completed, due to nurse practitioners not being able to order early obstetric ultrasound. But yeah, it's been completed that a few times, and without any dramas. It's pretty simple. No dramas with dispensing from the pharmacy or anything like that. No hiccups. Yeah, that's really it's been pretty easy. It'll be good if we don't need to do ultrasounds.
Can I ask a question about? Oh, sorry, Carolyn's first.
I'm just really excited and clapping. Thank you.
My question is for providers. So I'm working in health promotion, and because we can't get funding to run a service, although I'm in the Grampians region and we know what it looks like. The other fear is, of course, that if we did get allocated a hub, that we wouldn't be able to staff it. But my question is, because we've got women that live in these remote areas and access to services is hard, that if someone had a really clear clinical picture and that it looked pretty safe of the gestational assessment clinically based on history, how comfortable would everyone be prescribing without that ultrasound? Say if they were a telehealth. Any thoughts on that? If it was difficult for them to access due to distance, funding, all that.
Kathy, you go.
Oh, I was going to say, look, I'd feel okay, although we're starting up, like we do have telehealth ad hoc, but we're starting off a telehealth service, but we're not starting off without doing ultrasounds. We just want to do it really conservative to start with, because you can't actually often easily review the client. I know with time we'll switch to that, but yeah. But I sort of feel we need some practical, like, primary care guidelines as to when and when not to order when it's fine not to order an ultrasound. And I think it'll become routine after a while.
Yeah, I totally agree with you, Kathy. Like, my confidence is fine, but I wouldn't actually expect everybody to feel confident about that at this stage. But yeah, I think it will become, a more routine, hopefully. I always tell the women that I'm dealing with is that they do this in Canada. Been doing it in Canada for years.
Yeah, I know. And like as everyone was saying, like it's even harder, where you are, Jen, getting built ultrasound, I would imagine, but it's even hard in Melbourne, with the timelines. So.
Oh, Louise, did you want to add anything to what Joe said?
Yeah, hi everybody. Yeah, so I suppose here in Bendigo we're very fortunate. We've got 4 GPs. I have done a couple, but I probably have been even more conservative than Joe and done them when Karishma's been with me in the clinic. So I don't do any outreach clinic in terms of that. And a couple of our GPs have done early medical abortions where the history of the last normal menstrual period has been very certain, and so that's their sense of confidence and their sense of competency. Yep. So I think it's just slowly doing it. Yep. And so far, all good.
Great. So did anybody have anything else to add about that item, about midwife practitioners, etc.?
I just want to ask a question. For the nurse practitioners in terms of being able to order an early obstetric ultrasound, will that change? Who knows? Yeah.
Oh, I think Patty's coming back on, which is a good thing. Oops. But yes, I would. That's my answer to you, Ange.
Yeah.
Yeah, here she is. Hi, Patty.
Hi,
can you hear me?
Yeah.
Yeah.
That was excruciating.
We continued on with the next item. So
that's fine.
We discussed the nurse practitioner midwife prescribing. Yeah, which seems to be for Joe and Louise seems to be going well. So that's a good start. Yes. We all stood there like stunned mullets waiting for you to do something. Well, anyway, I'm not quite sure where you want to pick up.
I'm so sorry about that. I'll just because I know we're running out of time now, but I very quickly will just give you an example of a couple of guidelines that match us. If I can share. Can you see the screen? No?
Not just yet.
Not sharing. Okay, I better go down to share
I'm getting a
screen.
message, Patty, that your bandwidth is low, so maybe sharing a screen might. Yeah.
Okay, well, look, I'll just talk about them basically. Yeah, if that's okay. Yeah, I have a feeling it's something to do with the air up here in Meanjin. I'm not sure what's going on. I'm on the hospital, not the hospital, the hotel Wi-Fi. So the examples I was going to give you were that we, in terms of, I'll just, sorry, see if I can have a look, but not share. Just so I don't forget what I was going to do. So with regard to testing, can you all still hear me? Oh,
yeah.
Has it gone again?
Yeah, no, we can hear you. We can hear you.
Okay. I'm having a mental breakdown here. So with regard to testing, consensus-based guidelines were enabled for a decision with regard to routine testing for hemoglobin and for rhesus D status, blood group and rhesus D status. So both are not required routinely. And the reason that is we weren't able to reach evidence-based is that no one's ever tested these things. Other than cohorts that have shown no rhesus immunization, huge cohorts across Canada and Denmark and the North Scandinavian countries when there were paucity of supplies. So because of the grading methodology, you're not able to call that anything other than, very low. So the practice point is that obviously clinical judgment with regard to risk factors, for example, with anemia in certain populations and individualization of care for the rhesus D negative patient is to be supported. And so that is really important. Remember that the college followed the British initiative during the pandemic that we didn't have to test for or supply immunization for rhesus negative women, and that holds for both surgical and medical less than 10 weeks. And so we can now reference those guidelines as well as overseas guidelines, because we still do have a large number of general practitioners and other primary care providers sending women into the hospital and for anti-D. So that's useful, I think, for practitioners. And then ultrasound's another useful one. And this is an evidence-based recommendation. The evidence grade was low to very low, again, because no one has randomized these studies. But the results were based on two very large cohorts, which were observational. The largest one was the 2021 publication of what I have loosely called the pandemic papers, which was the big work out of the NHS and BPAS in Britain, where they compared their intervention of stopping doing testing because of the pandemic. They stopped ordering routine antenatal ultrasounds and compared the cohort before that intervention and the cohort afterwards. And it was extremely reassuring with regard to the incidence of ectopic pregnancies, the incidence of ongoing pregnancies, and the incidence of complications. So the gestational age of the pregnancy, the recommendation is it should be determined prior to an abortion. This could be by clinical means, history including the last menstrual period, and that aforementioned large cohort study and the paper that was developed from it comes with a logarithm for assessing when somebody might be at risk. In their study, 80% of women did not require an ultrasound scan, and the other 20% would have been because they've had a previous ectopic or had had multiple cesarean sections. So with regard to ultrasounds less than for surgical less than 10 weeks and for medical, a ultrasound may be seen as useful by the practitioner if there's a suspicion of an ectopic or there's other clinical concern, and care can be managed in line with the patient's preferences with regards to this. A lot of work went into studies that looked at remote and rural cohorts across North America and Europe, showing that by improving that this measure really improved access in areas where women could not normally get a timely ultrasound, and decreased the ongoing pregnancy rate, partially they believe because patients were getting access to the abortion much earlier. After 14 weeks, all should have ultrasound scan for gestational age and placental site to exclude placenta previa if there's been previous uterine surgery. So again, I think these are useful guidelines, and would be interested in how they might, your opinion on how they might support practice. Follow-up is also another slight change from other guidelines that have been issued by the college previously. This is an evidence-based, again, low-grade evidence, that serum or urine BT-HCG for exclusion of an ongoing pregnancy in early medical abortion up to 10 weeks. If using a low sensitivity urine test, which goes negative at a beta-HCG of approximately 1,000. The recommendation is to perform this at 14 to 21 days, which is somewhat later than previously. And if using there's a misprint there. And if using a beta-HCG quantitatively, an 80% drop at between days 8 and 16. And the graph will help explain that, in that there's quite a wide variation in what the beta-HCG drop will be between the 25th percentile and the 97th percentile. And if you look at around 8 days, that is the area where there will be significant differentiation. Now that is different, and that was to take into account the practicalities of reviewing patients as well. And just a little shout out to the first pregnancy test, which was the very, very low sensitivity pregnancy test using the African clawed foot frog, which was injected with early morning urine from the patient. And if she was pregnant, the frog would lay eggs. So I'm not suggesting that one for follow-up, but just
there's something about killing rabbits too, like something.
Yeah, they also killed rabbits as well. Yeah. So the little froggies then invaded Great Britain and caused a huge amount of fungal infections in other small mammals and rodents, apparently, and the rest is history. But just to show us where the progress in follow-up has come from. So I'll finish there, but there was quite a few very basic supportive guidance that we could indicate. The guidelines themselves go through what we call the narrative of how we investigated each and every clinical point. I haven't gone on to this group about the surgical abortion points. That can be a presentation for another time. But I'd be interested in whether anyone's had a look at them yet, or had a look at the decision aid. And in particular with the decision aid, we want to have another go at it and make it even more user-friendly. So we're probably going to have another look at that in the next 6 months or so. Any comments or questions?
Patty, can I ask, was the, oh, sorry, Catherine.
No, go.
Was the decision aid for use with a health professional, or was that for consumer use? I just had a quick look up.
It's to use when it's to use during the interview. There are consumer only decision aids and values clarification tools. We've got several of them on the women's website, and I think Sexual Health Victoria also has. This was one to sort of talk you through a decision aid with the patient.
Thanks.
I thought they were great. I was really happy to get them, particularly about the ultrasound. And I really like the fact that they don't mention that you have to sort of counsel people about options of continuing with the pregnancy, or because that's still a really common sort of thing that we get with doctors.
Or compulsory referral, compulsory referral for social work, or The next lot of guidelines that they have decided they're going to look at is miscarriage management guidelines. So there's going to be an overlap and an interconnectivity. So I'm really pleased that this early pregnancy work is being really pushed in this area, with the context being to improve access. So I will leave it there. I missed the very important information from Lou about how it's going, but I will catch up with Lou and Joe about how the prescribing is going for you guys at a later date. The last thing we were going to do was just a little bit of a roundup. We always finish with a roundup and news from around the state, and we've already mentioned that Sunraysia has become a hub, so congratulations to Sunraysia. Does anybody else want to share anything before I gave you a couple of little tidbits?
At VCNACC, sorry, as a nurse practitioner, I've just been supported by Sexual Health Victoria to complete IUD insertion, so I've only got one more placement to go, and they've been awesome.
Oh, fantastic. That is great to hear. Yeah. And so, if we can look at more and more ways of getting our nurse practitioner colleagues up and running with this, it's fantastic, Joe. The other good news is that as of Friday, and I had to sit down when I got this email from Paul Brougham, who is a GP obstetrician in Latrobe Valley, based in Traralgon, and a GP who we've worked with and supported as he developed his own practice around early medical abortion and trying to get a surgical abortion list at Latrobe, and for the Latrobe Hospital to support the providers of early medical abortion and to do curettes when and if necessary. I'm really pleased to say that on Friday, and I think it's due to some changes in the leadership at the hospital at the level of the head of department and a senior O&G, but as of Friday, they have decided, and it's been endorsed by the CEO, that they will provide stop services, so surgical termination of pregnancy up to and including 12 weeks and 6 days. To be affected immediately. So that is a huge change for that valley. And we noticed that when you provide a service like that, it really provides a hub for spokes to go out to the other community services. They've also been given funding to develop another community-based early medical abortion provider. So this is just fantastic after many years of advocacy.
Patty, I think the data that I got from you guys from the Royal Women's really helped with pushing that last little bit as well. So that was really good. So
that was the data around where patients are traveling from.
Yeah.
And that together with the Atlas. Is really helpful. So fantastic. And whatever we can do to help. And the other thing was just a little incidental way that I noticed that a service was up and running, that the Grampian service Grampians Health, where Natasha Frawley's been doing a fantastic job to try and get a surgical, well, she has got a surgical service in Ballarat, but she was trying to get a surgical service at Horsham and at Ararat. We recently had a patient, a young woman who was 10 weeks being referred by her GP, and we were able to from the Ararat region, and we were able to quickly check that the Ararat list was up and running, and she got a service 2 days later. And I thought that that was a sign of a bit of hope for that area that you've been you know, so eloquently painting the dearth of services in, Carolyn. So we will continue to try and you know, support them. Maryborough, which is also in the Grampians, are not a hub, but they have been, you know, just bravely starting, and they have a coordinator who just emailed me today to say she's just appointed a nurse for that service, and they're supported by Dan Wilson, the GP obstetrician up there. So, you know, there's inroads, a little bit more inroads. And then in terms of Melbourne itself, I am really proud to announce that both the Western Hospital and the Eastern Hospital, so Box Hill, have started surgical services after being pushed and encouraged by the Department of Health. So 2 of our consultants are going to be working at those services, 2 of the consultants that work with us at the women's. So again, one up to 14 and the other up to 16 weeks. So this is all, you know, small increments, but it's moving in the right direction.
I think Sam.
Does anybody else have?
Sam's raised their hand.
Yeah, Patty, I was just wondering, are they public service?
So who's that?
It's Sam from Gateway Health.
Oh, yes, public services, yes.
Oh, fantastic. Okay, because we refer to the Austin quite a bit, so that's great to know that there are other options.
It's worth knowing that both the Western and the Eastern are using catchments for their services, so they probably won't, still the only hospital in Melbourne without any kind of catchment or criteria will be the Austin. And the women's will take people who are rural and can't access local services as well. But I don't think that Western and Eastern will have much additional capacity.
There'll be catchment, but don't forget the Northern for that Northeast corridor as well. They now have 2 lists a week.
And Kyneton.
Oh, and sorry, Kyneton. Yes, let's not forget Kyneton. Yeah, which is also going. So just a shout out to you all and a round of applause, and thank you all very much. And I apologize for my connectivity issues this evening. When do we meet again? So when's our
those dates haven't been finalised yet because obviously they haven't, but we'll
but it'll be in the new year.
Yeah, I'll send out notification early in the new year about the quarterly meetings, but so it's a couple of months grace, and but as soon as we've got the new information in the new year, I'll send out information to everyone.
Thank you all, and have a great evening.
Thanks.
Bye.